Prinzmetal angina, also known as variant angina, is a fascinating clinical phenomenon because it flips the standard model of heart disease on its head. While typical angina is caused by a supply and demand mismatch due to a fixed physical blockage, that is atherosclerosis, Prinzmetal angina is caused by a transient functional obstruction. Here is how the coronary artery spasm work without needing a permanent blockage. In a healthy heart, coronary arteries dilate or constrict slightly to regulate blood flow. In Prinzmetal angina, a segment of a coronary artery becomes hyperresponsive. When a spasm occurs, the smooth muscle in the artery wall contracts so forcefully that it temporarily shuts the vessel. This leads to transmural ischemia, meaning the lack of blood flow affects the entire thickness of the heart muscle wall, not just the inner layer or the subendocardial region. This is why you see ST segment elevation on ECG during an attack, which usually mimics a heart attack. In usual angina, you get ST depression most of the time, as the ischemia is confined to the innermost subendocardial layer of the myocardium. The hallmark of this condition is that it can also occur in angiographically normal coronary arteries. Several triggers and underlying dysfunctions drive this. Endothelial dysfunction. The inner layer of the blood vessel, the endothelium, normally produces nitric oxide to keep the vessel relaxed. If the endothelium is broken or sensitive, it may fail to prevent constriction or even trigger it. Autonomic nervous system imbalance. Excessive activity of the sympathetic, that is fight or flight, or parasympathetic system can trigger the smooth muscle to overreact. Hyperreactivity of smooth muscle. There is often an exaggerated response to vasoconstrictors like acetylcholine, serotonin, or even cold weather and emotional stress. While the cause in stable angina is a fixed plaque of atherosclerosis, in Prinzmetal or variant angina, it is a temporary smooth muscle spasm. Trigger could be physical exertion or stress in stable angina. In Prinzmetal angina, it often occurs at rest, cycles at night or early morning. ECG change in stable angina is usually ST depression, while transient ST segment elevation occurs in Prinzmetal variant angina. Vessel is permanently narrowed in stable angina, while it can be completely clear between episodes in Prinzmetal's angina. There could be association of spasm near fixed obstruction as well. These episodes often happen between midnight and early morning. This is likely due to the circadian rhythm of the autonomic nervous system and changes in vagal tone during sleep, which can make the coronary vessels more prone to snapping shut. Coming to ECG findings in Prinzmetal's angina, transient ST elevation is the most critical sign. If you capture the ECG while the patient has chest pain, you see the elevation. If you repeat it 20 minutes later after the pain subsides, the ECG might look completely normal. Increased R wave amplitude during the peak of a spasm is a feature of Prinzmetal angina. T wave peaking. You might see very tall peak T waves immediately before the ST segment starts to rise. Arrhythmias. Because the ischemia is transmural, these spasms can trigger ventricular arrhythmias or AV blocks depending on which artery is undergoing spasm. Like right coronary artery spasm often causes bradycardia or heart block. Sometimes, if a patient already has T wave inversion from a previous issue, a Prinzmetal spasm can make the T wave look upright and normal temporarily. This is a trap. It is called pseudonormalization and actually indicates acute ischemia. In the cath lab, provocative testing is done sometimes to induce coronary artery spasm. Ergonovin or acetylcholine can be used to trigger a spasm while watching the ECG and the artery on the monitor with due emergency care precautions. If the artery narrows and the ECG shows ST elevation, the diagnosis is confirmed.